Immigrant Health under Trump's new rule. I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today. In this webinar, we'll explore ways in which the Trump administration has already limited access to health care and social benefits among undocumented immigrants well before an obscure new federal rule has even gone into effect. The rule redefines and greatly limits who should gain permanent residence immigration status in America by expanding the definition of who might become what's called a public charge or a burden to society. In a climate of widespread confusion, fearful immigrants, including those who have mixed families made up of people with or without legal status, have dropped or pulled themselves and their children, sometimes U.S. citizens, from benefits such as Medicaid and food stamps, with real-life consequences. The effect of this public charge rule could reach far beyond the nearly 400,000 people seeking green cards. The rule's chilling effect could impact more than 2 million people in California alone, by one estimate. Here to help us decipher the implications of the rule and ways to tell stories about its impact, we have three distinguished experts. Elizabeth Aguilera, a multimedia journalist who covers healthcare and immigration for Cal Matters. She's also the co-founder of Migratory Notes, a weekly newsletter that synthesizes exceptional immigration journalism. Professor Tom Wong, the founding director of the USC Immigration Policy Center and an associate professor of political science at the University of California, San Diego. He previously served as an advisor to the White House Initiative on Asian Americans and Pacific Islanders under the Obama administration. His research focuses on the politics of immigration, citizenship, race and ethnicity, and the politics of identity. And then we have Dr. Altaf Sadi, a neurologist and physician researcher at Massachusetts General Hospital and Harvard Medical School. Previously, she was a fellow at UCLA's National Clinician Scholars Program. Dr. Sadi completed her neurology training at Massachusetts General and Brigham and Women's Hospitals in Boston, where she also served as chief resident. During residency, she worked in Tanzania, Zambia, and the Navajo Nation with Boston Healthcare for the Homeless and the Doctors Without Borders telemedicine program. Dr. Sadi also coined the term sanctuary clinic to talk about ways that clinics can help make patients feel safe. This webinar is offered thanks to the generous support of the Commonwealth Fund and the National Institute of Healthcare Management Foundation. You can tweet about the webinar at the hashtag #PublicCharge. A quick word about our format today before we turn to our speakers. We'll be hearing first from our panelists, and then we'll turn it over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions into the control panel of GoToWebinar. You can write us there if you're experiencing technical problems as well. And we will be archiving this webinar at centerforhealthjournalism.org. Now let's turn to our speakers. We're going to start with you, Professor Wong. Until quite recently, no one had really heard of public charge, but it's burst into our consciousness. Can you tell us what this rule really means?
Yes, thank you for everybody who's joining the call today, and for the Center for Health Journalism for having me on. I am going to talk a little bit about new research that we've done out of the center on the potential impact of the public charge rule. But before I dig into that new research, I'll give a little background. So when it comes to the center, just a quick note that the center is relatively new. We launched in March of 2019. The center is designed to do rigorous social science research in real time as policy debates unfold. So when it comes to a little bit of background about public charge, we know that on August 14th, 2019, recently DHS published its final rule on titled Inadmissibility on Public Charge Grounds. So the final rule was published after nearly 270,000 public comments were submitted to the notice of proposed rulemaking. For folks who are unfamiliar with how federal policy works, if an administration, for example, wants to change policy, it has to articulate what that policy change is going to be. publish it in the Federal Register, and then allow for public comments. So the notice of proposed rulemaking that has been over a year or almost a year since it was initially published. And so it's been a long ride for those who have been working on public charge. If you look at the Federal Register in the final rule that was published, you'll also see that the Department of Homeland Security responded to many of the public comments. And we have this summary here that while some commenters provided support for the rule, the vast majority of commenters opposed the rule. So that's from DHS itself. And pending court challenges, the rule is set to go into effect October 15th, 2019. So when it comes to what the final rule does, previously the programs that were considered for public charge purposes included cash assistance for income maintenance, Social Security income, temporary assistance for needy families, cash assistance, and, quote, programs including Medicaid, supporting individuals who are institutionalized for long-term care, for example, those in nursing homes or in mental health institutions. These programs are articulated on the USCIS website on public charge. You can still find information about the previous public charge rule on the USCIS website, since the new rule has yet to take effect. So the final rule will add Medicaid with certain exceptions, the Supplemental Nutrition Assistance Program, SNAP, or food stamps, Section 8 housing, Section 8 project-based rental assistance, and federal public housing to the list of programs to be considered for public charge purposes. I'll note here that the Medicaid exceptions include Medicaid use by children under 21 years old and women during pregnancy. That includes up to 60 days after pregnancy. So the final rule also defines public charge. So previously, we have not had a definition of public charge, although public charge has been part of the language of U.S. immigration policy for over a century. There hasn't been a formal definition. So part of what the rule change does is define public charge as, quote, an alien who receives one or more public benefit for more than 12 months in aggregate within any 36-month period. So this applies to people who are seeking admission into the U.S. So there has been a lot of news media coverage, for example, of individuals outside of the country applying for visas to enter into the U.S. Who are already confronting changes to how these applications are being vetted vis-a-vis public charge grounds. We should also not lose sight, though, that those non-citizens who are already in the U.S. who are seeking to adjust their immigration status are also subject to the public charge rule. In particular, the 12 million undocumented immigrants living in the U.S., to the extent that there, for example, might be a legalization program down the road, they would also be subject to the public charge rule. So when it comes to the impact of the rule, here's a sort of summary of the landscape. Individuals who are either applying to enter into the U.S. or trying to adjust their status have, for centuries in the U.S., have had to prove that they wouldn't become a burden on the state, a public charge. And now we have a growing list of programs that the Department of Homeland Security will consider when denying visa applications or denying individuals petitions to adjust their immigration status. And given the increasing list of programs against the backdrop of other immigration policy changes, then as has been reported in many different contexts, there are sort of anecdotes of chilling effects of just the possibility that the use of certain public programs would make somebody inadmissible. So when we think about the potential impact, it's hard to systematically evaluate impact. There has been research, for example, that looks at census data on households that use public benefits, for example. It's hard to infer from that data how many would actually be, quote unquote, chilled by the public charge rule. And so out of the center, we have a Undocumented in America project. What that is an ongoing survey, a probability-based sample of undocumented immigrants in San Diego County. I am happy to answer any technical questions, but for a quick summary, there has never been a phone book of undocumented immigrants to use to conduct surveys with. We essentially have a phone book of undocumented Mexican nationals in San Diego in partnership with the Mexican consulate. So using this sample frame, we've been able to conduct now 7 questionnaires on different immigration policy changes under the Trump administration. So one of the questionnaires that we recently did is on the public charge rule. So what we did is a survey experiment. I won't go through all of the language in the survey experiment, but we randomly assigned individuals to hear language about the existing public charge rule. And then we randomly assigned individuals to hear language about the existing public charge rule plus the proposed changes. So this was during the period before the final rule was published. So when we talked about the proposed changes, we were talking in hypothetical terms. So I want to note here that the effects that I'm going to show are likely amplified now that we have final language, and this policy is set to go into effect October 15th. But when we think about the potential impact, what we're trying to do with this survey experiment is basically say, here's the existing rule. If we add these other programs to this existing rule, will that change your behavior? So the survey experiment helps us uncover the causal effects of the rule change. Now, in terms of the outcomes of interest, you'll see we talk about emergency healthcare services, preventative healthcare services. We also talk about free immunization services, such as flu shots at county public health centers. And of course, food stamp usage and other welfare-related programs in California. For those with children, we ask the parent to talk about the likelihood of getting emergency healthcare services for their children or preventative healthcare services or free immunization. For respondents with children in K through 12 education, we also ask about getting free or reduced price school meals for their children. So what you'll see on the bottom half of that table is that we are asking individuals about their behavior related to programs that are articulated in the public charge rule. For example, food stamps in California, it's called CalFresh, as well as programs that are not articulated in the public charge rule. The experience with Alabama's HB 56, in summary, was that there was language as part of its Show Me Your Papers statewide law that exempted undocumented immigrants from use of free county health services for communicable diseases. The language was intended to help ensure public health in the state of Alabama. But post HB 56, even those programs that were exempted, there was a statistically significant decline in usage among Latinx individuals in the state using county administrative health data, and Latinx individuals being a proxy for those who are undocumented. So what we know from previous policies like Alabama's HB 56 is that the chilling effects likely extend beyond just those programs that are articulated in the policy, hence the number of items that we focused on here. So what you're seeing is a table of results. When we look at the first row, for example, emergency healthcare services, 71.5%, if we ask about one's likelihood of getting emergency healthcare services when needed under the existing rule, the undocumented respondent says 71.5% of the time that I am either likely or very likely to get emergency healthcare services when needed. But in the treatment condition, again, where we talk about the existing rule plus the proposed rule, that percentage is only 56.5%. So that's a 15.1% decrease, which is highly statistically significant. When we get at preventative healthcare services, 50.6% of undocumented respondents say likely or very likely. So we already see that there is a sort of health access gap when it comes to preventative versus emergency healthcare services. So our baselines are dramatically different. But when we look at the treatment condition, 32.3% are likely or very likely to get preventative healthcare services when they hear about the proposed rule. That's an 18.3% decrease, which is also highly statistically significant. For undocumented respondents, free immunization services, again, we worded it as free immunization services such as flu shots at county health clinics. We also see a statistically significant decrease of 9.1%. For individuals with children, here are maybe some concerning findings for those on the phone. For emergency healthcare services, we see undocumented respondents say that almost 9 out of every 10, of course, I'm going to get emergency healthcare services for my children if they need it. When they hear about the proposed rule, we see a 6.6% decrease, and that borders on statistical significance. Now, this finding is intuitive. Even though we see a drop, we still see most undocumented parents say that, yes, if my child needs emergency healthcare services, I'm going to get it. But when we move to preventative healthcare services, we see an 8.6% decrease, and that is statistically significant. When we move to free immunization services for their children, we see a 12.4% decrease. That is also statistically significant. When we shift to children in K through 12 education, there's a 9.1% decrease in the likelihood of getting free or reduced price school meals for their children after respondents hear about the proposed rule. So again, I think we are most likely underestimating the effects of the rule change, because in the survey experiment, we created a treatment that described the proposed rule change in hypothetical terms. Specifically, we use the language, there is a proposal. And so to the extent that the final rule goes into effect on October 15th, we're likely to see not only chilling effects for those programs that are articulated in the final rule, but also chilling effects across a broad range of important programs that help serve our communities and protect the health of our communities. I should note that for those undocumented respondents who have U.S. citizen children, the results are qualitatively similar, meaning the trends that I just described for the entire sample of over 500 respondents is also true for those individuals who have U.S. citizen children. So as mentioned earlier, the effort to target specific individual migrants for whatever purposes rarely can be as precise as just targeting the individual. So when we think about immigration policy changes like the public charge rule change, then we are talking about the individual who exists in a family, and that family can include U.S. citizen children, so those in mixed immigration status households. So with that, I will end and turn it over to the next panelist.
Great. Thank you so much. We're going to hear next from Dr. Altaf Sadi. Dr. Sadi, we understand that you have done research looking at how the fear of deportation can affect health. Talk about that a little in the context of this public charge rule change.
Well, thank you so much and for hosting this webinar and for inviting me on the panel. I think it's really important to understand the fear around public charge fits within a larger environment of fear that has been sown with other anti-immigrant policies that have been implemented. And we had seen sort of effects on people seeking out health even before some of the proposed public charge rules, where people were sort of forced opting out of prioritizing their health, sort of making this personal calculus that risking their immigration status or potential citizenship just isn't worth it. And so that's what I wanted to focus on, is sort of broadening our perspective and then talking about my research specifically in terms of how healthcare facilities have been responding. So Professor Wang's report and new data is really powerful in showing how this fear affects use of public services like clinics and public benefit programs, WIC, SNAP. And so I won't talk about that too much. I think in addition, what we've seen is an increase in worsening mental health outcomes. And that could be from a variety of reasons, from stress that's associated with constant state of uncertainty or experiences of discrimination that people are experiencing. And there's data there that shows that it's not just immigrants who are affected by these policies, but also members from the racial ethnic groups that are perceived to be immigrants. So I bring this up because in addition to a chilling effect, we're also seeing a spillover effect into communities that are not directly impacted by these policies. We're also seeing, beyond these two, we're also seeing impacts on things that may not be intuitively health related, but have downstream health consequences. So for example, people reporting that they're afraid to get out of the house or drive. So whether that is driving to their appointments or driving to pick up their medications from their pharmacy. We're seeing people who are afraid to go outside and exercise, which has downstream health impacts that we're going to see many years down the line, right? And that is not going to be immediately captured in the sort of data we can analyze now. We're also seeing people just afraid to engage with their communities more broadly. So the flip side of that is when community spaces are perceived to be safe, there continues to be active engagement. And in an interview I had done with a school district official that had been promoting their schools as safe spaces, they had commented how they actually saw an uptick in parental involvement in the schools among their immigrant families because parents were perceiving the school as being a safe space for them. And I want to use that to transition to what institutions can do to allay the fears of immigrant patients, which is what I had been interested in exploring as a research project. And I had really seen a lot of amazing efforts at healthcare facilities taking place to protect and welcome immigrant patients. So efforts like instituting drills on what staff should do if ICE shows up on the premises, to adjusting training for providers on how HIPAA or privacy laws include protection of immigration status. And I wanted to capture that in a more systematic way. So we conducted an interview-based study, conducted interviews in 5 states, in California, Texas, New York, Florida, and Illinois, that have the largest undocumented immigrant populations. And we felt that it would be fair to sort of target these states because healthcare facilities in these states would be most likely to see a pressing need to address these specific kinds of patient concerns that I talked about. Then we identified healthcare facilities in each of the 5 states that were involved in implementing these policies and actions. And, overall, it ended up including 27 healthcare facilities, federally qualified health centers, academic, private, and county institutions. And third, we contacted the relevant people at these healthcare facilities to participate in the study. And these are people who were involved in formulating or implementing their facilities' actions in some way. It included clinicians, administrators, senior executive leaders. And overall, we conducted 40 interviews across these 5 states. And before I venture into the policies and actions, just to give you a flavor of what healthcare facilities were doing, I did want to say that the motivating factor for healthcare facilities was not was not just a decline in patient visits. And I thought this was something that had surprised me. So one of the things that we saw was at some healthcare facilities, they actually talked about an increase in immigrant patients coming in for behavioral health issues. And this is something I haven't seen as much reported in the media, but this was something that several healthcare facilities we were at talked about. And the other aspect that had motivated some healthcare facilities to think about doing something was that they also just saw their workforce affected. And that was because many members of the workforce were immigrants themselves. So whether they had people, quit their jobs because of termination of TPS, or who had members of the workforce who were worried about their DACA status or the Muslim ban. And the other way that the workforce was impacted was that at some facilities that the staff were facing attacks by patients who were targeting them, through just verbal abuse. So at one facility, a patient overheard two nurses speaking Spanish and said, Trump is president now, you can't speak Spanish anymore. And I just mentioned these because what we found was that there are really other motivating factors for healthcare facilities to think about what they could do at the institutional level to make sure immigrants were feeling welcome, and that included patients as well as their staff. And in terms of the policies and actions, we identified 13 different policies and actions that healthcare facilities were implementing. And for the sake of time, I'm just going to focus on 4 of them. We're going to be releasing a toolkit for healthcare facilities this November so that these policies and actions can be replicated nationwide. But again, I'm just going to review 4 of them. So one of them was thinking about designating private and public spaces. And this is important because law enforcement, immigration enforcement can show up in public spaces without a warrant or permission, but that doesn't need to be the case in private spaces. So at some clinics, they started creating 2 different waiting rooms, for example, where they would have an outer waiting room that was for public, for all walk-ins, and then they would have an inner private waiting room for people who had checked in. I'm just going to read off a quote from an administrator in Texas who shared a story that really illustrates why, creating these different waiting areas that were private versus public would be helpful. So she says, "We had a patient who was an immigrant who refused to stand up when his name got called because he was afraid that if there was any agents within the facility that they would recognize his name and pick him up and take him." And so sort of creating these spaces that were more private helped facilitate some ease. We've seen distribution of Know Your Rights cards in waiting rooms, so as simple as just having the brochures in the clinic rooms or waiting rooms. But more innovative ways have been even community health workers providing teaching around Know Your Rights education directly. So they're teaching about hypertension, blood pressure, and then also incorporating this into the teaching to the patients. We're seeing a lot of really innovative ways to try to nurture immigrant empowerment and civic engagement. And again, the spaces that healthcare facilities traditionally do not venture into. But at some places, they would have voter registration drives outside the facility. They would have skill building sessions for patients on how to talk to legislators or how to talk about their story to the media. And then talking about how to incorporate deportation preparedness for families into larger emergency preparedness. Telling families, make sure you have potential legal guardians that are identified so that your child doesn't end up in foster care. And then talking to providers about how to have these conversations in a way that is sensitive. And in places like Texas and Florida, where I conducted some of these interviews, this emergency preparedness also included, natural disaster preparedness, particularly around hurricanes, because that was another layer of fear that immigrant patients had around accessing services in case of a natural disaster. I'm going to briefly talk about sort of the use of the term sanctuary, which I had initially used and was interested in seeing what healthcare facilities whether they were using it as well and how they were feeling about it. And so there a lot of places they were putting up posters. So this is an example of one from the San Francisco Department of Public health, where they're proclaiming that you're safe here. At some places, they initially did use language around sanctuaries. They say this is a sanctuary clinic, this is a sanctuary space. But what I saw was that although some of them had began with the use of the word sanctuary, there was really a shift away from this because it was felt to be falsely reassuring and ambiguous, or translated very differently in different languages, and to render it essentially meaningless. And related to this, just to talk about another variation from places like California and New York, we saw that there was significant difference between public facilities and how they were advertising their efforts to the media. So in places, in facilities in Texas and Florida, for example, that have different political leanings, many clinics were doing all of these things, but really wanting to avoid publicity because they didn't want to draw protests or bigots coming to their clinics and targeting their patients. So this is a quote from a senior level executive at an F2HC in Texas. She says, even though we're providing the support, we are cautious about advertising how much support we're giving. We're trying not to put a target on anyone's back. This would go even in terms of efforts around talking about public charge, just other efforts, that there's really a lot of variation in different parts of the country. But across the board, healthcare facilities are stepping up to say, look, we see our patients affected and we want to do something. And I'm going to wrap up there, and I'm happy, look forward to the Q&A and look forward to releasing our toolkit this November. That's it.
Thank you, Dr. Sadi. Elizabeth, we've just heard about how much fear there is in the community. How do you report with sensitivity on this topic and get people to have the confidence to share their stories with you?
Hello, I just lost my slides. Hold on one second. Let me find where did they go? Here it is. I wanted to answer that question, Michelle. I think that there is definitely a way to report on this issue, and there has to be, as you said, sensitivity in terms of the folks who are going to be impacted. But before I get to the sensitivity, we heard Professor Wong talk about what the definitions are and what this means. And I think that before journalists can really go out and talk to people about how this might impact their life, we as journalists have to really understand what this rule does, what it means, because sometimes I think people may even ask us questions about whether they may or may not be impacted. And I would never say let's try to explain to someone whether they would be impacted or not, but I do often find myself saying, well, this is my understanding of what this rule might do, and then they make a decision about whether it may or may not impact them. So I think one of the key things is understanding what it does, because there has been a lot of confusion about what it used to be, what it's going to change to, and who exactly is impacted. And there's seems to be two rings of impact. There's the ring of folks who would actually, could face repercussions because they may be on the programs or may in the future be on the programs. And then the folks that Dr. Sadi was talking about specifically, who are afraid that they could somehow get caught up in this, even if they are not technically in the definition. So there's sort of two groups here that we're talking about. And then, one of the things that I found in writing about it is, of course, defining public charge, being very clear. A lot of the stories that have come out since the announcement was made have been very sort of high frequency in terms of the fear and what the Trump administration is doing, but not very clear on who exactly this is going to impact. And I think that's really important to have in the stories. The public charge rule is going to affect people who have been admitted legally, and then of course those are who are here undocumented. But these are people who are not citizens. These are people who don't have their green cards. And then even for those, as Dr. Wong mentioned, who would be impacted, there are a lot of exclusions. So making sure that we understand, right, that it's not going to be something like receiving Medicaid while you're pregnant is not going to impact your future ability to apply for legal residency, because I think there is a lot of confusion about that. And our job, along with telling people stories and being sensitive, is to explain the context of that. Who is it going to impact, and how many people, if you can find out from your state or your local city or county on how many people are actually on the programs, and then using the research that we just heard from Dr. Wong to think about how many people might be impacted because they're afraid, because they would not take advantage of services. And so we're talking kind of about two people, and understanding how it will work, I think, is one of the biggest things that I've seen as I've been reading through stories as this rule has come out. So take this as an opportunity to clear up the confusion over who's impacted and how it's going to work. Something like a really good explainer. And again, using the before and after, which Dr. Wong had a great page in his research about what it used to be and what it is now. And what I have on the screen is just kind of a few examples that could be used. But also, one of the things that I find that I've been having discussions about is, even though now it includes cash aid and Section 8 housing vouchers and SNAP, which is food stamps, how many people are on those programs? I think there is this belief when we hear reports saying now people are going to get in trouble, basically, or not be able to move forward in their immigration process if they get these programs. Well, how many people are actually allowed to be on those programs? There has not been a lot of reporting on the fact that sometimes these programs aren't even open to folks who are undocumented, or to folks who do have legal permission to be here but who are not green card holders, or who have not been in the country for a certain amount of years. And so I think that there's also that level of nuance that we could really provide for people to say, even though the public charge rule talks about these programs, not a lot of people are allowed to apply, but they might have family members that are on, or they might be getting food stamps for their US citizen children, and therefore that impacts how they might feel about this public charge rule, and it might lead to those decreases that Professor Wong was talking about in participation of these programs. So I think there's a lot of really detailed things that we could do as journalists to explain, here's how this works, here's who they're going after, and then of course the larger story being the fear factor and how that could impact people's health, at home, in their community, on the ground. And then this is where we get to the people who are actually impacted or afraid, explaining who they are and why this matters. One of the ways to get to these folks is, talking to sources. If you're not already in these communities, and even if you are, sometimes these organizations are great for finding families, individuals who might be willing to share their story. And there's no one better than community clinics and organizations that help low-income families for services, or just, healthcare or education, who know what people's stories are. And, local immigrant advocacy groups, attorneys who help immigrants, they definitely are working with people, even right now, who are in the process of maybe finding out if they can apply, who would probably be very concerned about this. Help centers, help organizations, school parent groups, churches and charities that help low-income folks, especially in immigrant communities. Those are all places where you're going to find those liaisons to individuals who can tell their stories. And there's a few good reasons for going through those organizations if you're not already embedded in a community, is that if that person makes an introduction, there is a sliver of the trust factor, because they trust their pastor or their attorney, they trust their social worker at that help organization. They may be more willing to talk to you about their situation. And again, finding out, what is this really about? When you talk to people, are they fearful? Are they actually on a program? Do they plan to get off of the program? One of the key things with this new rule change is that it's not retroactive. So you're not going to be docked if you've been taking advantage of one of these programs, if you've been a beneficiary. But if you are, once the rule goes into effect or in the future, then that could be something that they will consider. So I think there's also clearing that up for people. Finding a person, if you find someone, some of the good examples are someone, of course, who are using the programs that might be impacted, someone who, oh, why does this keep happening? Someone who is legally in the country but is afraid and might quit the program, and someone who maybe isn't getting any benefits for themselves but is for their children or a family member, because so many families have mixed status that they may be considering disenrolling their citizen children or their senior citizen that's in their family who is entitled to benefits. And those are all of the things that we can talk to people about personally. In terms of talking to people, if you can speak the language, if you can, is one of the most important factors. But even if you can't, there is a way to be sensitive about this topic, and there is a way to have people chat with you. Again, using those community connectors like those attorneys and social workers and advocates who can help introduce you to families who will often, if you were asked them, will be willing to participate in an interview with you, maybe also translate if you don't have someone to translate for you. And when they're present, I think that also sometimes gives people a little bit more confidence in the process. I know often as journalists, we don't want that other person to be present, but depending on the situation and the family, sometimes it's very helpful to have those folks there. And sometimes they also help break the ice. They also may reiterate a question that you've asked in a different way because they know that person's personal story and sort of know what to draw out of them. So I would say, like, I know we tend to put up a little bit of a fuss if someone wants to come along, but this may be a situation where that is okay. With immigrants in this situation, I really strongly encourage journalists that I speak with to explain yourself fully. What are you doing? Who are you with? Why do you want to talk to them? Explain where the story will be. Explain that their name will be public. Be upfront about that their name will be out there, because sometimes we introduce ourselves as journalists, we start asking questions, and people may not quite get that their name, in my case at Cal Matters, will be in newspapers across the state, possibly on the air with our public radio partners. So they don't know that this is going to go that far and that wide, or they may not even understand what where you're coming from. For instance, in my case with Cal Matters, I explain that we are a digital outlet, but also our stories run in newspapers. So I try to be very clear about that. If they're very fearful and they say no, I definitely wouldn't push on that. My personal philosophy is I don't push individuals to talk to me on any topic unless they are, of course, the center of the story and are the only person that you need to talk to, or they're an elected official or an executive, because they don't get a pass. If your outlet allows you to give them the option to be anonymous or to just use a first name, if you sense that hesitation, might be something you could offer people. I don't usually do that right up front, because sometimes you explain who you are and that their name is going to be, in your newspaper or your outlet, your radio station, your website, and they might still agree. If you sense some hesitation, you could talk about that. Sometimes advocates will ask if that's a possibility. And if someone says no, of course, you find someone else who's willing to go on the record. There are immigrants, even in these fearful situations, who are willing to talk about their situation. And then if you go through an organization, they often will be able to tell you. They know who, the talkers are, and they know who has a story and wants to share it. So those are great resources to have. In terms of advancing this story, we've seen now a lot of the stories come out that say there's been this change. What is that going to mean? I think it's really important to find out how many potential people will be impacted. And I think there's two ways to look at that, right? The people who will actually be facing consequences if they remain on a program or or feel like they're connected to a program in some way, and see if your state or other organizations know these numbers. Find out, in states like California, where I am, services are sometimes state funded. So for instance, in California's Medicaid program, which is called Medi-Cal, offers benefits to folks who have been in the country illegally, children specifically, and come next year, they're going to also offer the program to 19 to 25-year-olds. And so will that count as Medicaid? How are they going to know whether you're federally or state funded? So those are some of the questions to ask. And then how do people plan to support themselves without these programs? If they decide not to get immunizations, if they decide not to continue to go to health clinics, what does that mean? And so then some story ideas are just to focus on the facts and the educated research, which there is quite a bit now in terms of what that's going to mean for people. And finding out where the policy meets the people. That's what this story is about now. I feel like there will be lawsuits. It's unclear if it will actually begin on October 15th or not, but there is a lot of potential stories and other effects. The fear factor is really important, and we can explain who's impacted and how. We can ask for those numbers. Think about your state, what's covered, what's paid for by the state. There's a lot of historical analysis that could go on, but also economic comparisons, looking at how immigrants' income changes over time, how they close the gap, because that is one of the focuses of this change, is that they don't want people to be a financial burden on the state. But you could also do stories that show how people, immigrants over time, close that wealth gap. And while they might need assistance at the beginning, they eventually are pretty self-sufficient and successful. Medicaid in particular is expected to see a pretty big hit in terms of disenrollment, so that would be somewhere else to look. And then I think that's something Dr. Sadi said in terms of other effects. The downstream effects are things that we could talk about. Transportation, not driving, walking, shopping are the local economies taking a hit because people are not out as much as they used to be. And then the workforce and the economic participation. I think those are all really great story ideas. I have some links here to stories that I thought did a pretty good job of talking about these issues. And then the AP story where it says doctors' new rules will mean sicker immigrants was a really different kind of take on this in terms of looking at what doctors were seeing. But I will pass it back to Michelle because I'm looking forward to the questions.
Yeah, so thank you to all three of you. This has really been excellent. We're going to turn this over to our audience now to ask questions of our three speakers, and you can type your questions into the control panel. While people do that, I'm just going to start out with a question of my own, and perhaps for Professor Wong. One of the things I thought I understood about this new public charge rule was that it didn't just specify that you are somebody who's used these benefits, but as I understood it, and I'd welcome your insight, it's somebody who has the potential to use these benefits in the future. Could be a litmus test. And so I then wondered, could this be a broader way to just deny access and permanent residence to somebody who's low income, even if they have not used these services? Is that something that you have looked into?
Yeah, so thank you for the question. Just a little bit of background for folks. There may be a lot of stories to tell about how USCIS, the DHS component agency that's primarily responsible for making these public charge determinations, how individuals within USCIS are getting guidance on how to implement public charge, how they're interpreting that guidance, and whether or not there's variation within the agency itself. So part of what a USCIS officer is supposed to do is look at the totality of the circumstances for an individual's application or petition. So you are absolutely right. When we think about public charge, this is likely to be a public charge. So what the USCIS officer is doing is, again, looking at the totality of the circumstances and making a determination of whether or not the person is more likely than not to be a public charge as defined in the new rule. Again, it's 12 months of public benefits usage over a 36-month period. So one can imagine that if there is a sentiment at the top to use public charge to essentially close the door to immigration or folks adjusting status in the U.S., then the implementation of this policy can quite literally do that. Even if there's not that sentiment at the top, there might be some individuals who, on the one hand, interpret public charge and use it in the way that I just described. But on the other hand, there might be some individuals who, within USCIS, take a sort of different approach to how they evaluate the totality of the circumstances of an individual's case. So as we get nearer to this final rule going into effect, we will likely see guidance either from DHS to USCIS or USCIS leadership within the agency to USCIS officers about how to implement the new rule. And I think there are going to be a lot of stories to tell there. And with respect to data, there will certainly, for those individuals who do data journalism, there will certainly be an interest in looking at whether or not denials based on public charge grounds increase post October 15th, 2019, if the rule goes into effect.
Thank you. And I'm going to just start asking some of the questions from our audience. Rahani Fesher says, the rule is not retroactive. However, would those who are renewing benefits be at risk?
This is Elizabeth. I can take that. I think that the way that it is reading, and from the folks that I've spoken with at the agency, is right. If you renew, when they do these reviews in the future, it isn't going to be based on, oh, you had it already and you renewed it, so therefore it doesn't count against you. I think they're looking at time and, a time and place once this law is in effect. And so if someone renews and they have the program in that time frame that they're being reviewed, it would be taken into consideration. I don't think it's like a grandfather situation. That's my understanding.
We have a related question from Justin Weiser, who asks, what exactly is the impact, if any, of the proposed rule change on people who have legal residence but would like to apply for U.S. citizenship? In other words, they have a green card and want to become.
This is Elizabeth again. So on that one, and Professor Wong probably knows this better, but my understanding is it's not for folks who have green cards. It doesn't impact them, and it doesn't impact the application for naturalization. Is that right?
That's correct. Those who already have green cards wouldn't be subject to this new public charge rule. So again, it's for those who are applying to be admitted into the U.S. So one can imagine, prospective immigrants in their countries of origin who want to come into the U.S., or non-citizens who are currently in the U.S. who are trying to adjust their status to primarily that of a green card holder. So once you have a green card, there are there's a different basket of worms to try to overcome when it comes to green card to citizenship, but public charge is not one of them.
And Elizabeth, moving in a little bit of a different direction, when you were giving your presentation, you said it's important for reporters to distinguish between whether a benefit is a state benefit or a federal benefit. Can you explain why that would matter?
Well, the public charge rule is based on the federally funded programs, and so there is definitely some work to be done in terms of distinguishing, right? Finding out, will your state benefits be held against someone? And I bring that up because in states like California and some other places like New York, states have sort of taken it upon themselves to expand on these federal programs and to allow some folks who may not have qualified under the federal guidelines to take benefits. So in California, some undocumented groups are allowed to apply for Medi-Cal, which is our Medicaid program here. And it is under the agreement that the state pays all of their expenses. There's no federal funding that goes towards the care of those folks unless it's something that would have already been allowed. So for instance, if an undocumented person who is allowed to be on the program, which in right now, deferred action for childhood arrival recipients are included in Medi-Cal coverage. And also once January rolls around, any 19 to 25-year-old, regardless of immigration status, will be allowed. So if someone in that group is pregnant, that would be considered funded federally. It's very complicated, but because the federal Medicaid program already allows for emergency coverage for pregnancy, that would be paid for federally, but that's also exempted under this public charge rule. And then the state of California pays for the rest of that person's health needs, for however long they're on the program. So those are questions that I'm curious about too, in terms of finding out how does that impact someone's eligibility to later then apply for legal status if they're participating in these programs. Because is it an interview? Is it a form that you check to say, do you receive Medicaid or Medi-Cal? How are they going to distinguish between what states provide and what the federal government has paid for? So I think there are some really interesting questions on that. In California and in other places, there are also some exceptions for housing vouchers, depending on who is funding those. And so those may also be a place to do some research to clear things up for people in the community, to say if you're receiving housing voucher from the city or county of Los Angeles, or from New York and this organization or that organization, then this doesn't impact your future potential to apply for a legal permanent residency card. But if you're taking straight Section 8, that could be an issue, but maybe not if it's for your children. So those are all the really specific kind of questions that we could ask to find out how this is, going to impact people on paper. And then, of course, the fear factor is a different piece of that impact.
And we have a question from Patrick Pine. He says, I remember the issues that arose with SARS and Legionnaire's disease. And by the way, we're opening this up to all the panelists to respond, so feel free to jump in. I remember the issues that arose with SARS and Legionnaire's disease and the significant impact on public health. Is there some concern that this rule, as implemented, could greatly increase the risk of significant public health challenges? Would that be a different approach for a news report on the issue?
Yeah, this is Tom. I'll just jump in briefly. Yes, I think that is a concern. So when we think about past policies intended to essentially exclude immigrant communities from public programs, in California, we have a literature on Prop 187. One study in particular comes to mind where tuberculosis patients weren't showing up for their regularly scheduled doctor's visits for fear of being deported under California's Prop 187 in 1994. There's also a large literature on how the health-seeking and help-seeking behaviors of Latinx communities changes when there are state laws that are passed, like Alabama's HB 56, which I mentioned a little bit earlier, but also Arizona's SB 1070. So if we sort of imagine looking into a crystal ball and trying to get some sense of what might be the sort of broader range of consequences of this public charge rule, then California's Prop 187, Arizona's SB 1070, Alabama's HB 56. These are policies that have been studied, and there is an existing literature that shows negative public health consequences as a result of those policies.
This is Dr. Sadi just jumping in. So I would add that just in terms of thinking through some of the specific public health challenges. Professor Wong's report, they talked about decline in people getting immunizations. And again, that's been seen with prior state level policies. Decline in prenatal visits and care for newborns, that's been seen, with even some subsequent papers showing decreased or lower birth weights among both immigrant and sort of U.S. citizen Latina moms who were affected by the policies at large. So there are a host of different public health challenges in addition to just people delaying care and so not showing up until it's an emergency and sort of consequences of that.
We have a question from Esmeralda Fabian. How is this rule, or how might this new rule affect services for students at public schools, such as free or reduced lunch or special education services?
Yeah, I'll take that. So part of the survey experiment that we fielded here in San Diego County showed that undocumented parents would be statistically significantly less likely to participate in programs that provide free or reduced price meals for their children. And there was a very large group of respondents who had U.S. citizen children. And so when we think about the sort of potential implications of this rule that extend beyond the individual immigrant, we're talking about children who may potentially go hungry in school because parents fear that even a program that's not articulated in the public charge rule may put them potentially at risk of one day adjusting their immigration status. And so there are likely other similar programs, but in the research that I discussed earlier, we asked specifically about free and reduced price school meals, and we saw a negative effect. And just to reiterate, that's probably underestimating, because when we fielded the survey experiment, it was still just the potential rule change. Now we actually have final language and a policy set to take effect October 15th.
Thank you. We'll just ask two more questions because we're running a bit over. For you, Elizabeth, from Melon Mayer, who said, should you worry about the unforeseen consequences of an immigrant going on record with his or her name, and then they aren't aware of what that could mean and they end up being deported? Is this the kind of thing that keeps you up at night?
I have spent a lot of time thinking about that. I've been writing about immigration most of my career, whether it was my main beat or not. And so what I found for myself that really helped is making sure that I overly explain sometimes, what this could mean for them, that people will see their name, that that they could, people will know what their status is if they're, sharing with me that they are undocumented or whatever their status is, or if they're sharing that they are on a program, then people will know. People who know them will know. And if they have any concerns, that we should talk about it. That is how I have been able to continue to do this work. And a lot of people are fearful and they will not speak with you. And some of them are okay with using a first name or just being anonymous. And I find that sometimes when they take that road, it is a little bit sort of a breath of relief, and as a sense, as a journalist, because I don't, no story I don't think is important enough for someone to have that fear in their life or to be facing certain consequences if someone were to show up knocking on their door because of a story. So I think that making sure that I explain absolutely as much as I possibly can where the story is going to go, that the fact that their name will be there if they allow me to take their photo, then also that their photo will be out there, and explaining what that means is sort of, I think, the only thing that we can do in terms of making sure that people have all the information they need to make that decision. And also explaining to folks, I once met a young man actually at a rally who was front and center. He spoke at the podium. He was, right up there. He got his photograph taken. And when I had spoken to him on the phone, and he had asked me only to use his first name. And when I spoke to him at the rally, I said, they've broadcast your name here and everyone is taking your photograph. Like, even though he had said one-on-one that he didn't want to be identified having participated in this rally as actively as he did, he sort of put his name and face out there, which really put me in a quandary because I had agreed to only use his first name, and then had to explain to him that because it was out there, it was public, it was on a public street, all the TV cameras were there, other reporters, and everyone was going to use his whole name, that I probably needed to do the same. So I think that really explaining to folks what this means is the best thing we can do as we cover the story.
Thank you. We'll take one final question. It's from Paulina Velasco for Dr. Sadi. She asks, can you describe the healthcare facilities that you see taking steps to reach out or immigrant clients? Does this take extra resources, and where do facilities in low-income communities find the money to do this? And are there some that might want to but cannot do so because of financial constraints? And it's a multi-question question. So I guess just pick what parts you want to answer. Are there
I think
money
yeah,
for these
that's a great question, and something that I asked during our interviews as well. And what we saw was really it was a shifting of resources rather than taking new resources. So, for example, a lot of facilities set up like a designated task force that dealt with immigration issues. What they did is they incorporated this into existing groups that might be meeting to talk about community outreach, for example. So they added what to do around immigration in existing community advisory boards or existing boards that met around community outreach issues. And I think that's how a lot of places sort of got around the limited resource issue, was trying to combine it with other priorities or other efforts. The other example I'm thinking off the top of my head was around creating new policies on what to do if ICE shows up in the hospital, for example. And at several of the healthcare facilities we were at, they combined this with writing larger policies around what to do if law enforcement shows up. So particularly, let's say in Chicago, where I went, where maybe the likelihood of ICE showing up is not very high, but the likelihood of a cop showing up is something that happens very frequently for us if we're in hospitals. And so getting risk management and other people who would think about that already to the table, and then saying, okay, well, how then do we add the immigration piece to it? And so, yeah, I think that's one way that different facilities got around the limited resources, was combining it with other existing efforts that had some relationship.
Well, I want to thank our three excellent panelists and the audience for all their questions. We are going to conclude our webinar. Please know that later today we will have the webinar video and all the PowerPoints archived on centerforhealthjournalism.org, where we also have resources related to this topic. We'll be sending all of you a very quick evaluation survey, and we'll hope that you could fill that out. It helps us with our work. Thank you so much, and have a good day.